Good evening, everyone. Thank you so much for joining us this evening for Wine with WIPM. We are very excited to be with you and to discuss basivertebral nerve ablation, the procedure evidence, and patient identification. I'm joined here tonight. I'm Karen Patel. I'm an interventional pain physician. I practice in New York City. I'm also a pain medicine program director. I'm on the board of NANS and on the board of WIPM. And I'm joined with the lovely Jennifer Marie Lee, who I will let introduce herself.
Welcome, everybody. I hope you have a glass of wine with you. I do not, because in Seattle, where I work, it is not yet 5 o'clock. So I'm here in my clinic room. I work at up in the Northwest at a private hospital system up here for the time being. And I'm super excited to talk with you about this Intracept procedure tonight. We can begin the next slide.
I want to offer up a very special thank you to our sponsor, Relievant, who is the manufacturer of the Intracept procedure, the branded basivertebral nerve ablation that we'll be referring to tonight. Next slide.
And next slide again, please. All right, so the Relievant procedure or Intracept procedure is a treatment for degenerative disc disease that causes vertebrogenic pain. So this is an interesting perspective in the lifetime, in the world of pain management and orthopedics, in which we have discussed and tried to understand what causes pain that occurs with degenerative disc disease. Historically, the focus has been on actually the disc. And so let's talk a little bit about that disc and the anatomy at that site. So when a disc begins to degenerate, there are a lot of factors that contribute to that. If you look at the data and at demographics, tons of factors, including hereditary studies. There have been like twin studies that have shown associations in early onset degenerative disc disease. Mechanics, and there's a lot of controversy about whether those mechanics are more vibratory or torsion. That is still not yet decided. There are nutritional influences. Tobacco use certainly has an influence on the development of degenerative disc disease as well. But what happens in this condition is that there is an intimate relationship between the end plate of the vertebral body and the disc. In fact, they're so intimate that they are connected with capillary network that extends from the vertebral end plate body into the disc through this cartilage system that resembles type 2 cartilage, as we see many other places in our body. When there's a disruption in the capillaries or in the very fragile structure on the end plates through which these capillaries traverse, it causes, it threatens the nutrient supply to the discs. And the discs are already very threatened in that way. The discs represent the largest tissue body in our body that is avascular. And in fact, in that center of the disc, this tissue is 8 millimeters from the supply of blood. So it's incredibly dependent on these tiny, fragile little networks of capillaries that come from the boned end plates. And if we have stenosis of capillaries, if we have little microfractures of the end plates that occlude the os that those capillaries come through, nutrient problems, all of these things are going to result in poor nutrient supply and therefore degeneration of the tissue matrix. Next slide, please. Oh, go ahead, Karen.
I was just going to add something. So we know that the nucleus structure has about 20 pro-inflammatory factors. And so when we have disruption in the disc, what we see are we see these changes in the end plates. We actually see neovascularization, as Dr. Lee just explained, and neoinnervation. And what's interesting is that, disc degeneration that you will see presented in the patient's typically 20s or 30s will be followed up with the development of motor changes, typically in the 4th or the 5th decade of life. And if you think about our patients, that makes sense a lot. I have a phrase, and we'll discuss more about patient selection, but I have, and you might relate to this, Dr. Lee, when I have a patient who I've been seeing for a long time, I say, their history sounds so modicky, but they don't have changes yet. And and there are patients who, as I've learned more about this procedure, in the past few years, I would say, your history sounds so perfect with, vertebrogenic pain, but I've never seen changes in the bone. And then you order a new MRI, and then there, lo and behold, after 2 decades of, or a decade of living with the result of disc degeneration, you end up seeing those modic changes. And we'll talk more about that.
Yeah, that makes sense to me, Karen. It's kind of a slow process that is the culmination of a whole lot of factors that may be hereditary, they may be lifestyle choices, but the result is a kind of a slow degradation of the disc itself and this neuroinflammation and all of the sort of fire that happens with that nociceptively on the end plates. We can go to the next slide, please. Perfect. So Kieran was just introducing the idea of modic changes. Certainly it's not new to any of us ladies out there treating chronic pain. Modic changes are the term that we use when we see these changes in an MRI, and they're classified between 1 and 3. With respect to eligibility for the Vertiflex procedure by Relievant, we're looking for type 1 and type 2 modic changes. So these are the modic changes that represent neuroinflammation. And type 2 is when that inflammatory environment becomes infiltrated with fat. Once you move into type 3 modic changes, you're going to see both on T1 and T2 weighted MRIs a hypointensity. And then you're sort of past the mark with respect to the efficacy of something like Vertiflex or Intracept, because what's happened is that fatty infiltration has been replaced by sclerotic tissue. Next slide, please. So as I alluded in the beginning of this lecture, there's really been kind of a revolution in the way that we think about discogenic or about pain from degenerative disc disease, which has really been led in charge by this procedure. Preceding the advent of this procedure, certainly the Relievant folks were not responsible for marking out the anatomy. The anatomical knowledge was existing already that they designed this ablation procedure around. But that's just what this is. It's converting the treatment focus from the disc to the vertebral end plates, and specifically to this basivertebral nerve. So in decades past, we had things like biaculoplasty or IDET, and these were treatments that were targeting the disc directly for treatment of pain. But what we know is that that disc is really not very innervated. And in fact, the density of nerve innervation is so much greater on those end plates. And it all, for the most part, it tracks back to the sinovertebral nerve. The anterior end plate and the anterior disc, for that matter, is innervated by the gray rami communicantase from the sympathetic tract. But what we see is that this one large trunk that is nearly in the center of the posterior vertebral body, it branches thereafter to the superior and the inferior end plates. So that trunk, that central trunk, can become a really nice target for ablation if we intend to, and would result in hopefully providing relief of pain from the nociception at the end plate. Interestingly, Kieran had mentioned a few minutes ago about all of the many neural peptides and inflammatory chemicals that exist and are amplified at the end plate during degenerative disc processes. And there's actually increased density of receptors on the basivertebral nerve and the sinovertebral nerve as well in cases of degenerative disc disease compared to those specimens that are sliced and examined for patients who do not have this condition. Next slide, please. Do you want to take this one, Karen?
Sure. So just to review kind of the basics of the procedure for those who may not be familiar. And so this is a procedure where we are accessing that trunk, as Dr. Lee just described, which arborizes to both the inferior and superior end plates. We're accessing this through the pedicle. And the goal is it's similar, but it's very distinctly different than the approach for a kyphoplasty. In this case, we want to stay a bit more posterior in order to catch, if you see that where it says number 1, you can really see where that trunk of the before the arborization occurs. So we want to stay more posterior, and we want to stay in the middle of the vertebral body, similar to kyphoplasty in that respect. And so we're accessing through the pedicle. The goal is to create a channel by which we can then place a radio frequency probe and then ablate the trunk of the basivertebral nerve. And there, typically it's been, we've been using, ablations for 15 minutes. The newer technology and the new algorithm that Relievant has come out with, we are now able to, if we feel that the placement of the channel, the creation of the channel, and then therefore the placement of the probe is exactly where we would expect that trunk to be, we can actually opt for a 7-minute treatment algorithm. And that's a relatively recent improvement on the treatment algorithm. Next slide, please. So with that, we're going to delve into the clinical evidence that supports the use of basivertebral nerve ablation for the treatment of vertebrogenic pain. Next slide.
Okay, so we have here a very busy slide, and I can just kind of give you the high points to break this down. Relievant has really committed to some substantial medical evidence to support their therapy. The SMART RCT in the upper right-hand corner of this busy slide was their first randomized control trial. This was remarkably a trial where the basivertebral nerve ablation was performed and randomized and blinded against sham. So in this procedure, they actually did access the pedicle, but did not insert the catheter, the introducer, and introduce the thermal lesion. But the patient still was anesthetized, still had the very small incision to allow entrance of the trocar, and did have pedicle access. They had all the postoperative pain that they would expect from that experience. So the patient was truly was truly blinded. And then these results were followed out not for 1, but for a remarkable 5 years. And I know that we all are familiar with a lot of data out there. It's not common to see data out as far as 5 years in the space of pain management, or I should say even in the space of orthopedic surgery. In the Intracept RCT was their second randomized control trial. And this trial was also randomized, but against standard care. So these patients had vertebral nerve ablation, and then they did not have any other pedicle accessing procedure, but all of the other care that could be provided and typically is provided from medications, more conventional interventions, physical therapy, and the like. And then the last trial that we see here on the screen at the bottom is the prospective single-arm cohort study. So this is, of course, not level 1 evidence as an RCT is. However, these levels of evidence sometimes don't have the tiering of those levels of evidence doesn't always have the same sort of tiering in the way they relate to our personal practices. In fact, some real world studies that look at less stringent inclusion and exclusion criteria sometimes represent my patient population better than the pristine RCT patient selection and controlled studies. And so it's valuable to see a cohort study as well, and I'm grateful for that information to be presented here as well.
And what I'll say is that, these are not non-significant, right? I mean, we're looking at an independent single arm cohort study followed out to 12 months. I mean, that's significant, and so I always say when you're trying to apply a new therapy into your practice, it's best to base your patient selection based on the, randomized controlled studies that were responsible for the IDE, and to fall as close as possible as you can to do that. But then following that, it's important to see in deciding whether you're going to incorporate new therapies is to see, has real world data mimicked those clinical study results? And what we see here with Relievance technology, with the Intracept procedure, we see that that's exactly what has happened, that real world collections of data clearly mimic the same and similar types of outcomes that we have with more robust design studies. Next slide, please.
So the studies that we summarized previously have been aggregated into some clinical data that we're going to share in the studies that follow. In the aggregate cohort study, I think it's important to recognize that there was a really high retention rate at 3 years. So patients who were followed for that entire length of time, despite it not being the rigor of an RCT design.
Next slide.
So this is a little bit more information about the Intracept, which was the RCT controlled against standard care. It represented, well, actually both this and the prospective single arm cohort study had a population of patients that included 13 to 14% of those with a history of prior surgery. The numbers were not nominal, a number of 140 patients total for the RCT, and approximately 90 patients or greater in that prospective cohort study. The primary endpoints that they followed was the ODI reduction at 3 months after the procedure. But there were a lot of other endpoints that were followed, including VAS, patient satisfaction, and they were followed for a much longer length of time, which is represented in our data to follow. Next study, please. Next slide, please. So here we have the cohort data, the aggregate results for this, which includes, as I mentioned, the primary endpoint of ODI, Oswestry Disability Index, and also VAS at 3 months. So what you can see here is that the ODI was reduced from 46 to 19. That is an incredible reduction in the ODI, and in most cases represents a reduction of at least 2 levels of disability according to the categorization of that measure. And the VAS or NPS over time, it really matched or sort of shadowed the timeline in which the ODI reduced, and it was maintained for a period of 3 years. Which was as long as this study extended.
Yeah, I think this slide brings up a really good point. I think compared to other therapies that exist, obviously we're talking about this because it's a very elegant therapy for patients who have vertebrogenic pain. But I think one of the most notable aspects of the results is that we see patients who are considerably more functional. And so when they come into the office for follow-up visits, their focus is more on, hey, doc, I can do this now. I could do this now. I can do this now. I wasn't able to do that before. Whereas we're not focusing so much on a VAS score conversation. Dr. Lee, do you feel the same way with the types of results that you've seen in your office?
So I guess the one person that stands out in my mind, to be honest, was a gentleman who I performed this procedure on in the summertime, and he was in his mid-40s and had young children, and he had been so frustrated that he couldn't get down on the floor and play with them because he just had this need to constantly shift and move. And I'm telling you, when I saw him 3 or 4 weeks after the procedure, he was frustrated that he was still restricted from activity. He was asking why he can't go water skiing this weekend. I mean, he was really excited about certainly being able to play on the floor with his kids, this function that had been an obstruction to him previously, and felt really unlimited by his pain. I don't even remember kind of the before and after pain numbers on this guy, what sticks in my mind was that he felt liberated again.
Awesome. Next slide, please.
So
Well, I think other important measures to look at, in addition, obviously functionality is a wonderful conversation, a delightful conversation to have with your patients, as opposed to VAS scores. But we see with the Intracept procedure, we see an improvement in healthcare utilization. We see a significant improvement in opioid use 3 years post ablation. We also see that patients are requiring less interventions. Or are presenting to the office for less interventions. And overall, as we said, patients are moving a significant improvement in their quality of life in terms of their activity level. And, patients, you guys have heard me probably say this a lot, patients think they're getting better. And so, their global impression of how they're doing, the PGIC, is very important. And we certainly see that with these patients. Next slide, please. So this is a great study, I think, that really puts everything together that we were discussing. So you can see there's 4 lines there. And the top line are the patients, the 128 patients who were part of the SMART randomized control study. And then if we look at the line below that, it's a shorter line. It's the Intracept crossover to BVN group. And then below that, we see the Intracept treatment arm, and then the prospective single arm cohort study. And I think what's very astounding is that if you look at the baseline ODI, very similar in terms of where these patients started, and a very similar drop when we look at the 3-month, and then a consistent improvement compared to 3-month to 6-month, 12-month, 24-month, and then onward. Depending on the length of the study. And I think that really captures how these patients do. And certainly what my experience has been in my own office. I don't have patients who are out 5 years, and I don't think many of us do, but we will hopefully soon. And I think this graphic depiction really puts it all together about how these patients improve dramatically, and then their level of functionality, the improvement, it's consistent. It stays.
Yeah, I like this slide because we see a lot of slides in our space that, patient was not doing well. I did something to them and look how much better they are. And it's this slide is kind of enticing to me because it demonstrates reproducibility. It's like, oh, okay, well, the SMART study worked really well. Let's see that again. All right, well, the Intracept study showed us exactly the same things. Let's see it again in a different way. And there we go in the prospective single arm cohort. So, and just really absolutely reflected on one another.
And all of these patients, if we look for all of these studies, they started relatively at the level of severe disability. And by the 3-month mark, we see them moving into the level of minimal to moderate disability. And that's a significant change. Next slide, please.
This is really the same slide. It looks similar to the last because the last was a Swiss 3 Disability Index, and this is VAS. And it just is a simple slide after discussing the last because we can see that the same findings were demonstrated here. Next slide, please. And this is another way of looking at this data altogether. We are comparing on the yellow bars, which are the RCT, which was controlled against sham, to the blue bars, which was the aggregate cohort study, and sort of capturing or reorganizing the data in terms of how much improvement in pain the patients had. So it was not a mild reduction in pain. The ODI and the VAS scores, the margin or the sort of threshold for a success was a 50% reduction in pain. Anything at 50% or greater is going to be represented in those data sets we showed you previously. But this pulls out and really defines where those patients were from 50 to 100% reduction in pain among those that succeeded with this therapy. And you can see that the great majority of patients had more than 50% reduction in pain, and that remarkably, we had between a quarter and a third of patients in the study reported to have had a total 100% reduction in pain, which is like the holy grail of treatments. Next slide, please. Thank you. Go ahead, Karen.
So, if we look at the evidence and the discussion and the presence of basivertebral nerve ablation in our field, we see that there are 15 clinical study publications. There's been 2 randomized control studies, 1 systematic review published earlier this year, 3 meta-analysis, 5 literature reviews, and 3 independent studies. We have significant society support as well. The ISASS, as well as the ASPN treatment guidelines, which provided a grade A recommendation using the US task force quality measures in terms of conveying that grade of appraisal of evidence. And we have a CPT category 1 code active as of this year, January of 2022, and a NAS sponsored code with 5 supporting societies. In addition, obviously the ICD-10 code, which you all should know if you remember nothing else from this webinar, is that the code for vertebrogenic pain, it actually has its own code, is M54.51. And I actually have it in my office. I have it written on a big whiteboard so that nobody can forget it. Next slide, please. And so we're going to talk about, how to fit this into your practice and how to identify patients who may be candidates for basivertebral nerve ablation. So, I often say and even my medical assistants, I'm a big believer in training everybody who works for you, or works with you, whether it's an NP or a PA, whether it's your medical assistants, whether it's your front desk staff, so that everybody kind of understands what the goals of the game are and the types of patients we treat. And so my medical assistants or the advanced practice providers will often present a patient and they'll say, this sounds very Modicky. And we'll all laugh because they're absolutely right. They've kind of honed in the type of history that the patients will present with. And so vertebrogenic pain, patients are going to say, doc, I have this, aching, gnawing, throbbing pain in my middle of my back. And it's worse with activity. And it's worse particularly with any forward flexion activity or sitting. I often say, my most common activities that I hear about are unloading the dishwasher or unloading a front loading dryer, or even just bending down to wash the face, or putting a baby into a crib where you have to kind of reach and hold something heavy. And so, these are the classic type of movements, or putting groceries in and out of a car. These are the types of activities that, if a patient presents with pain in the middle of their back, that's aching, gnawing, constant throbbing, worse with activity, these might be some of the activity scenarios that you want to specifically ask your patients to try to hone them in to really identify, if it's weight bearing with flexion activities. And then, once we've kind of created that history, if you have a clinical suspicion, if they haven't presented with an MRI, certainly that might be an opportunity at that moment to order an MRI, and then to look for those modic changes that we described, both on the T1 and the T2 images. Next slide, please. And so specifically, we're looking for patients who have chronic lower back pain, or I like to say persistent lower back pain, that's greater than 6 months duration, and that they have failed to respond to conservative care. And in addition, conservative care being physical therapy, anti-inflammatories, activity modification, muscle relaxants, home exercises. And then at that point, we're looking for an MRI that demonstrates type 1 or type 2 modic changes at the vertebral levels. And then what is approved is L3 to S1. And again, distinguishing, to be very clear, the type 1 modic signal, you're going to see hypointensity on a T1 weighted image and a hyperintense image on a T2 weighted image. For the modic type 2 changes, you're going to see an hyperintense on both the T1 and the T2. Next slide, please. So this is an excerpt from the actual ASPN, basivertebral nerve guidelines. And so we see here, if we took at just exactly summarizing what we talked about, we're looking for a history of low back pain greater than 6 months that has not responded, may be described as aching, burning quality, worse with sitting, driving, forward flexion, any changes in position. And this may be described in a variety of severity. You may have patients who describe mild pain, moderate pain, severe pain. But the fact that it's present with all forward flexion or sitting, that's, I think, kind of the unifying theme with this type of pain. In addition, you may—
big thing. Karen, I think sitting is something that has really stood out to me. I mean, you could look at all of these characteristics and it could represent other types of pain as well that we see, whether it's facet generated pain or whether it's lumbar spinal. I mean, there's characteristics that become difficult to pull apart from one another. But when I start to see a patient that isn't responding to other methods, it's really persistent. And then if I hear that complaint of pain when you're bending just a little bit of forward flexion, I hear people all the time say standing to make my breakfast or unload the dishwasher. Those are like very characteristic symptoms that I think, I need to check the MRI or get one.
So in addition, you may find with these patients that if you percuss over their lower back, actually at the levels where their modic changes are, you may find that you're able to reproduce their tenderness. Again, I think what's more important is the history and the actual findings of modic changes on the MRI. But that is something in addition that you may document and put in your notes when we're trying to obtain authorization. So again, the type 1 modic changes, type 2 modic changes, and other things and other ways, so not all patients can have MRIs. So for patients who can have CT scans or PET scans, we're looking for the words of end plate degeneration. We're looking to see that ourselves. I'm always a big proponent for us to look at our own images, whether that's an MRI or a CT scan or a PET scan. And you may also, patients who are also candidates, maybe those who have active Schmorl's nodes as well. Next slide, please. Again, this is, kind of scooped another way, 6 months of chronic or persistent back pain that has failed conservative measures. We want to kind of then isolate that, just as Dr. Lee described. We want to be very careful in delineating anterior column pain versus middle or posterior column pain. And for those patients who demonstrate or give a history of anterior column pain, we want to look for the modic changes, type 1 and type 2, at the levels of L3 to S1. And for those patients, consider basivertebral nerve ablation. If we do not see modic changes, consider potentially intradiscal therapies or any alternative therapies. Next slide, please. And so, the ASPN primary findings and conclusion was that there is moderate to high quality evidence supporting basivertebral nerve ablation to improve pain, function, quality of life, opioid utilization, as well as accompanied by a high level of patient satisfaction and statistical significance. And so this was all based on the United States Preventative Services Task Force criteria for evaluating evidence. And so grade A evidence was put forward to recommend basivertebral nerve ablation. Next slide, please. And that concludes our slide portion of our talk tonight. But before we get into some practice management and personal development discussion, We wanted to open it up to any questions that you may have regarding basivertebral nerve ablation, the Intracept procedure, Relievant, the authorization process, any questions that you have at all regarding the therapy. Feel free to put them in the chat. Awesome. So, you know what, I think I think we have a question. Let's see here. The question is, when ordering an MRI, do you request a focus on end plate findings to the radiologist? So I think that's an excellent question. And that's also a great way to build your practice in some sense. So what I've actually done in my local area with the help of my Relievant representatives is to educate the radiology physicians who I work with in my community about this treatment, so that if we see patients who have modic changes, you know, just to know that there is an option, a treatment option for these patients if their pain is concordant with what we're seeing. So, you know, it's not quite ethical for them to drive patients to me, and that's not at all what I'm suggesting. What I'm suggesting is that for patients who come from my practice and I'm ordering an MRI, to request that, you know, if they do note modic changes or they see end plate degeneration or active Schmall's nodes, to put that language in the report. In my practice, you know, my advanced practice providers and myself, we look at our own images, and I hope, you know, all of you out there are doing the same. But sometimes, you know, when you have it mentioned in the note, in the report, that heralds you even more so to make sure you look at those images and review them yourself.
So we have another question regarding insurance coverage, which is a great one. It's super practical. As a newer procedure, the insurance carriers are all getting used to the idea, the indications, and varying degrees of comfort with supporting this procedure. It's improving continuously, especially with successfully getting a CPT code and having an ICD-10 code specific for vertebrogenic pain. What I can say is that the Relievant as a company understands that that can be a challenge for getting authorization for these procedures, and they offer a great deal of help for that. When I identify a patient, I have my patient, after I've educated them and they sign a consent form for the procedure, I also have them sign a consent form that allows me to share their HIPAA protected information with Relievant, so that they have a resource team to organize and submit all of the authorization information needed to the insurance company. And then they will go through multiple times. They're familiar with the processes for the insurers. And they will be the ones to kind of help drive that process of dealing with any denials and submitting appeals to that. On an average, what I understand from the company is that on an average, authorization is improving. It still is about 35 to 40%. Is that what you're hearing as well, Kieran?
Yes, you know, so I agree with all of that, and Relievant has been an excellent company to partner with in terms of support for helping us obtain access to this therapy for our patients. You know, the approvals have gotten so much better, and the coverage determinations, I think, that we're seeing popping up all over the country, I think is helping, you know, influence other larger carriers to develop coverage determination policies. And so I educate my patients. I say, look, you know, your pain is like, and your lower back is like a block of marble. And, you know, it's rarely that it's one thing that's causing your pain. So although a patient's history on the very first visit may be strongly that it's anterior column, and I may see those modic changes, I'll say to them, look, you know, you have other things going on. You know, I always use the analogy of the front of the house and the back of the house. Sometimes, more often than not, you're going to see vertebrogenic changes in the anterior elements, or disc degeneration in the anterior elements, and then you're going to see facet degeneration. So while they're in the portal, you know, and we're trying to go through the approval process, I'm not going to, you know, do nothing for them. I'm going to explain to them that, like, let's sign you up for the portal, let's get that going, but in the meantime, let's treat those other things in that block of marble that is your lower back. So let's start treating the facets for that posterior element pain. And so that's my advice in terms of, presenting yourself as the advocate for the patient and really explaining with as much transparency as their healthcare literacy will handle, that, you want to access this therapy for them, but in the meantime, you're going to treat other things that you can treat right away. I think we have some other questions here. We have great questions. One question is, can you elaborate more on the post-procedural restrictions? So I tell my patients, when we're doing this procedure, the incisions are really the size of a baby aspirin. And so I'm using Dermabond. There's no sutures. I tell my patients, I have them, wait 24 hours before, scrubbing aggressively at the area. But other than that, I tell them whatever's tolerated, back up on their feet, whatever they feel like they can do. Dr. Lee, do you throw in any other additional restrictions with that?
Yeah, I probably ask him to be a little bit more gentle. So maybe I'm being conservative, but knowing that I have had traversing the pedicle, and I consider that it may be a little bit more fragile. And so I'm asking patients to be avoidant of high impact activities like running or such. But otherwise, or lifting, I advise patients not to be lifting heavy weights for 3 or 4 weeks after the procedure and avoid impact.
You're in Seattle. So I think your patients are more active than my patients. They're not running and they're not lifting.
Yeah, it could be the case. If you don't say those things, they may be out there hiking or whatnot. So yeah. So, but otherwise, I would say most of the time, I'm sure I'm being more conservative than I need to. And most of the time people are questioning that and saying, are you sure? Why not? So, yeah.
But that leads to our next question, which is a really good question. It says, are there any contraindications with a chronic fracture in the vertebral body present without height loss? So for example, if the patient is not a candidate for kyphoplasty, but they do have degenerative end plate changes. So for that patient, my first and foremost question is, what is their bone health like? And what contributed to the changes that you're seeing? What is a history that has contributed to the changes that you're seeing? So, I think just as the ASPN guidelines have kind of put forward with us, and the frame of mind really needs to be, this is an excellent therapy that needs to be adapted to each individual patient's history. So if you're seeing those types of changes, you need to inquire a little bit deeper as to what else may be going on with the patient and how they develop those changes.
I know that Relievant, when they were first preparing to take this to market, they had to follow a lot of outcomes, and they did also follow the possibility of whether the thermal lesion was creating any sort of a vacuole that would put the patients at any increased risk of having compression fractures. Did not occur. But I do think that it's different conditions, and you'd have a hard time getting it covered, getting an authorization without modic changes present, which wouldn't necessarily be present with a compression fracture.
So there's some good questions here also. Are you excluding radicular pain? So I think that goes back to this whole concept of treating what you can. So a patient may have an element of vertebrogenic pain and have modic changes on their MRI, but they could also have a herniated disc and have radicular symptoms. And so that goes back to knowing what you're treating. This procedure, we are not treating radicular symptoms. If a patient is presenting with radicular symptoms, we need to take a deeper dive and to find out, what may be causing that. Whether that's foraminal stenosis, whether that is, herniated disc, whether that's, any type of other neural compromise. And so another one, Dr. Lee, maybe you want to take this one. One of our colleagues asks, can you explain your talk track to the patient about Intracept?
Okay, so I begin with talking to patients while I'm looking at their imaging. And I actually have, I'm gonna even reach right here. I did it. So I'm sitting in my clinic room, and I have next to me laminated sheets that show the pictures of the procedure. So what I do is I talk with my patient about their symptoms, explain that that could be caused or could be associated with all of this cloudy white business that I see on their MRI at the end plates where a disc is degenerating. And then I show them that laminated sheet, which is taken directly off the WIPM website, and shows the procedure targeting this nerve right in the center of the vertebral bodies. And that right there really seems to crystallize with patients. They like the idea of having a direct treatment rather than a smattering of medications or a birdshot approach with medications for other, whether it be muscle relaxants or otherwise. This is going to connect with another question that I see right down here. And that is, where did that go? That was the issue of whether insurance one of the other things that my patients really like is a question right here, whether it is something that is performed once or more than once. And as a non-myelinated nerve, this it's not repeated. So it's a one and done procedure. And that is also very attractive to patients.
Yeah, I think it's important to educate patients, like, in that sense. The way I often describe the Intracept procedure to patients in very simple terms, it's like turning notifications off on your cell phone, in terms of, not transmitting those painful signals. And it's a one and done procedure. So that once you switch off those signals, if the pain is coming from vertebrogenic sources, then you're really treating that. And another question here is, well, what do you do if the basivertebral nerve ablation doesn't work? Do you repeat the procedure? I think we answered that about repeating the procedure. It's not recommended, and it's not intended to, because it's an unmyelinated nerve. However, when patients don't have 100% relief or don't have significant relief, one, we have to revisit their expectations. And two, we have to revisit exactly, when they're experiencing this pain, what activities are bringing on this pain, and what other potential pain generators could be at play that we may have overlooked.
So another question that I see here is relating to if there are improved outcomes for this being performed with patients with type 1 versus type 2 modic changes. And we haven't seen any differentiation of that. And actually, the severity of the modic changes also is not an indicator of how likely it is to be successful. Are there modic changes, yes or no, type 1 or type 2, and does the exam align with that pathology?
So I think we have some professional development stuff that we can transition to, unless you feel like excellent.
Okay. So I don't have a lot more time to take of yours tonight. I have to say, this is I was left sort of like an open slate for to talk in some way about professional development or leadership within the space of pain management as women. And what immediately came to mind was the importance of being really purposeful about building a support group around you. I mean, I've always been somebody who gets connected, whether it's in my hospital system, joining committees, or in my community, even just volunteering in non-pain ways in my community. I like to be connected, but as I've been in this role now more than 10 years, I am understanding better continuously why it is really important to be very purposeful about professionally who you're surrounding yourself with. Next slide, please. So we're all here. For me, it's 5:30 almost in the evening. My clinic's closed. My medical assistant's long gone. And for many of you, it's later than that. So we are all here because we want education. And I think it's also because of that connectivity. it's not an accident that this is WIPM. It's not Aspen, right? Is that there's something about the philosophy or what we think could be the purpose of this particular organization. And there's lots of ways to feel connected. I think that it's worth thinking about them. I mean, and I'm sorry if this sounds a little middle school, but I'm going to just review a couple sort of simple definitions. And that community is a group of people that are in the same vicinity and have some sort of characteristics in common, but that doesn't mean they're your people. You can be I'm a mem, you know, I can live in Seattle, but and that's my community, but that doesn't mean that every Seattleite really is going to fill my heart. And that's the same for being in the community of pain management or anesthesiology or whatever it is. Your network is a funny word. Network really is about getting something from one another. It's not about supporting one another. It's not about understanding as much as it is like, I've got something you need, you've got something I need. How can we synergize here? And that's a transactional relationship. And then when I think of more of the connections and the type of what I'm looking for interpersonally, it is to build and support me in my professional development. I think of the word fellowship. And many of us have done fellowships. That's a term that is applied to advanced medical practice education. And it's the idea here is that it's a friendly association of people who are like-minded and share one another's interest. And I think in that kind of a word or that sort of a framework, we're getting closer to what I think we all should be aiming to build as our posse, if you forgive me for the 80s reference of a name. Next slide, please. So this is kind of an interest. The purpose of this slide is just this, for you to look at it and consider who is around you, who's surrounding you, because depending on who's around you or what kind of day you had, this could look like a friendly situation where the person in the center is being supported or listened to, or it could be intimidating. And I think that we need to think about this really intentionally. We can't always choose all the people that are going to surround us. But we can influence that, and we can position ourselves in ways that we are going to be in an environment of fellowship, and in an environment where people are not only asking from us, but giving back and helping our own development, and making us feel fuller as we leave those interactions.
I think that's an excellent point. I think it's important, and something that I at times myself have not done, and I have found myself kind of off the path where I wanted to be, is to not take inventory. The people who surround you can either fill your bucket up or empty your bucket. And I think, we have to all realize that we have only a finite number of days on this planet. And so if we surround ourselves and our patients with people who do not fill our buckets up and in fact empty our buckets, then we're not really living our fullest lives. And not to be, very kind of touchy-feely about it, but I think it's really something simple that we all need to do, because it's easy to get, into the routine of your work, whatever your practice setting is. And sometimes we carry around this like heaviness and we don't know why. But if you look at the people who you surround yourself with and who you choose to spend your time with, who you choose to work alongside with, you'll find that there are some who fill up your bucket and there are some who empty your bucket. And I think recognizing that and then asking yourself a second question as to whether you feel supported in your current environment, and if there are any changes that you can make to make yourself feel more supported and have your bucket more full. I think these are questions that are difficult to ask ourselves, but that we need to ask ourselves.
Yeah, you totally you're in my line of vision here, Karen. It's exactly kind of where I wanted to go with this, is that the role, I mean, every day we sit in clinic rooms across the country and people they bring us their problems and we pour our hearts and our intellect and our skills out toward them to try to solve and that's what we all are here to do. We feel passionate about reducing pain, improving quality of life. And there's a cost to that. I mean, it's pulling. I mean, I know we've all had days where we feel exhausted because we did our job really well. And we need to also be thinking about the people around us. And that doesn't just mean your boss or your immediate colleague, but it means who you intentionally, professionally are keeping contact with and calling on when things are tough. You need to be intentional because our time is short. And literally our time is short. There's only so many hours, so many conversations that we can have in any given day. And so they're valuable. These are the people that we are connected to are our choices and they should be chosen with care. So
I think something maybe you can relate to. You're like, have you ever gone on a longer vacation and come back and that first day in the office, you're like, you just feel awesome because you're like so extra present for your patients and your empathy level is almost restored. I think for any of you out there who's listening to this and can relate to that, I think that is proof in itself that we need to take inventory. And we need to know that, our ability to take care of patients is not just, identifying vertebrogenic pain and talking to them about, modic changes on an MRI. It's that, but it's combined with offering them empathy. And when we feel that we are fulfilled in our work environment, we have so much more empathy to combine with our skill set as interventionalists when we offer therapies.
Yeah.
Dr. Lee, what are your thoughts on that?
Totally agree with you. This is exactly where I kind of sort of the vibe that I was trying to put out there and discuss. I'd like to share the next slide, please. It's actually, Kieran, you got ahead of me. You knew exactly where I was going.
I'm sorry.
No, it's perfect, actually. Because you were talking about like just exactly this, the yin and yang of what people can either give to you or take from you. And there is going to be every bit of this in every day. It is absolutely a balance, but keeping an eye to where the balance is I think something that we all need to not forget, because we have to, we're going to be the best in our roles. We're going to be the best for our patients and feel the best in a long, successful career if we are not always having a drain on us from every direction, but also have a network that surrounds us and people that build us and fill us and grow us and support and challenge in the right ways. Next slide, please. So when I say to be intentional about building a fellowship or whatever word you want to use, rather a fellowship or posse or whatever word you want to use, what I mean for that is that, they have people that we draw into our lives who share maybe in many instances will be within our profession, maybe not in our community, maybe not in our network, maybe across the country or beyond, but they're people that will ground us when you are so frustrated. I have a colleague in California who I've called on when I'm so frustrated and I have a situation at work and I feel it was unjust and I'm so angry, and she's super grounding. She has a way of just asking a couple questions and I feel settled again and I can see things clearly. People that challenge you, and that doesn't have, this doesn't have to be a person that is always nice, right? It can be somebody that has that wonderful ability to be supportive, but be a little bit assertive with you and let you know when there's an adjustment you need to make. I think that we need to have people that reflect us well. So who see us who can communicate back to us that they see us and value us. Because that's, as we get into our careers, that's not always there. I mean, we're not having, like, in many jobs, there aren't assessments annually and such, we don't always get that external feedback and reflected back to us about how we're doing.
This is a great question. I'm going to segue into, and I'm pleased, we asked about questions related to the clinical portion of the presentation tonight. Please, if you have any comments about the topics that, Dr. Lee or I are touching on, please, share your experiences. We'd love to, share them with the group or ask any questions you may have. But this is a great question. At what point did you find a community that fulfills your professional development? Coming out of fellowship, I can imagine how lonely it can feel being a first-time attending. How can we as current fellows start building that fellowship community with others? Do you have specific recommendations? It's interesting. It's not just when you become an attending, it's when you do anything for the first time, right? And so as my career has gone and developed, and I've done different things, and it's my first time doing this or my first time doing that. There's Shonda Rhimes has a book called The Year of Yes, and in that book, and if you haven't read it, I really recommend it. She talks about first only different, and I think all of us can relate as humans to this concept of first only different, because we've all done something and been the first only and felt different. And so it's kind of this idea that, there's going to be continuous layers in your life where you are the first only different. And that the first time that may stick out to you, maybe when you were an attending, but it may also be when you become a department head, or when you become a program director, or when you become the first person to do Intracept in your practice. So I think it's getting ready to identify people who can be your network for each one of these stages, and who will support you and fill up your bucket with each one of these challenges. Dr. Lee, what's your advice on that?
Yeah, so my posse has developed from the time that I left fellowship. When I left fellowship, I was super connected to some of the other fellows and preserved those relationships. And then I felt like we just diverted into different directions, friendly, but just went different ways. And then I started meeting people in my community, in my medical community. Some of my relationships have been based out of patient interactions, a patient that was particularly challenging, or a patient that we had a really remarkable success with. And then that relationship is sort of sparked, and I find support in that person beyond just discussing a particular patient. I actually have found somebody that I consider in the front row of my posse, who is a medical device representative. And just, I feel like that person is useful to me because she sees the community, and I think she sees the spectrum of my world. And then, as I said, I have other people that are not in medicine at all, but they are other, I have to say, strong women in their specific their specific professional spaces. And a lot of the kind of experiences are translatable.
Specifically as a fellow, I mean, certainly join WIPM, come to the meeting,
Yes.
Get engaged. And, if you're looking for a mentor, we are all here to help and to help you through whatever career navigation that you're going through. I continuously go back to this group for myself, and so as a fellow, I would say get to know those who are in your fellowship year as you go to these courses all over the country, and as you go to the NANS lab and the WIPM lab and all of our other events. Get to know those who are your year, but then also try to identify some people to say, hey, would you be my mentor? Can you help advise me with regard to this aspect of my career, or navigating career and personal? So feel free to reach out to any one of us.
Yeah. Let's look at the next slide, please. So Brene Brown's probably one of the most overquoted people right now, I'd say. But nonetheless, I put this up here because I think it's super appropriate to what I have in mind. And it's like, connection is the energy between people when they feel seen, heard, and valued. And that is not just, that's you as an entire person. That's you in the work that you do, the direction that you want to go professionally, the balance that you're trying to seek between your personal life and your professional life, all of it. And I think that's why it's important to have people in your fellowship, your self-selected, intentional little fellowship that are in and out of pain management as a specialty. They're just strong people who you can depend on for this, for being understood and heard and valued, and to find judgment without, or find direction without judgment. And then one more slide, please. So, and then I think I will have to say, I was on the fence about putting this one in here, but I would say that there are times when there's just fundamental incompatibilities. And when you find yourself in a situation where, I would say I have found myself in a situation in recent times where I felt like professionally I was surrounded by people and a situation that was taking too much of me without building. It was like there's more of a draw than there is a deposit in my work right now. And it was, I think there's a point, absolutely there, it isn't a light decision, but there are times when you have to see this and ask hard questions about, is this a repairable situation? Do I want to put the energy into repairing this community around me, or this crowd around me? Or do I need to look for an opportunity where I can find where I'm going to flourish? And so I would just say this as a closing piece is that, think about that second or third slide that I had, where there was the stick person in the middle and people all the way around them. And if you find yourself surrounded, or when you are surrounded, and we all are all day long, people coming at us from every direction asking for things, we need to think about whether the balance, the yin and yang, is correct in, are we getting as much? Are we being built? Are we being supported? Are we feeling valued in equal part to what is being asked of us? And is that allowing us to do our job absolutely in the fullest way that we can?
So I'll say that in another way. I like to quote Drake a lot. And so I'll say you need to know your value and know your worth. And so if you feel that your current environment is not paying homage to your value or your worth, then sometimes you may need to walk away.
So we went from the super scientific right brain side to start the evening, and then we split into some soft left brain and some food for thought. And maybe that hit you right as you were having your second glass of wine. I hope that's true. I'm really grateful for everybody that came on tonight to join us, and really look forward to having an opportunity, hopefully, to see you in person at an upcoming event. If you see me, please come up and introduce yourself. I know
next slide. I want to talk to you guys about a very exciting event. So we're doing a MedEd Combine just for WIPM members, with WIPM board members as well. So it's going to be all women who are presenting and performing these therapies and talking about these therapies. And then VR headsets are going to be provided to attendees. And again, these are all priorities given to WIPM members. So certainly become a member if you're not officially a member, and look out for this event. We're all extremely excited. It's the first of its kind, and we're just trying to grow the community more. Next slide, please. And of course, the annual conference, mark it on your calendars, June 9th to the 11th. We are going to the Scott in Scottsdale, Arizona. We are very, very excited. It's an amazing venue, and I certainly hope to see all of you there and to get to meet you all in person if we haven't already met. The very last thing I will say to you all before we leave the webinar tonight is that if there are any topics that you would like to see us cover in these, Wine with WIPM sessions, please send them, through social to WIPM or to any of the board members, because we want to develop content that, is most relevant to all of you. So thank you so much for joining us, and I look forward to seeing you all soon.
Bye.